Hello, I'm Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. You're probably wondering, what the heck is this image? Well, it's a peripheral blood smear from a patient with mononucleosis. You see a number of red blood cells, and then you see some activated T cells, specifically two, that have this somewhat of a hugging of the neighboring red blood cells with this more basophilic or blue sort of glow where the cytoplasm touches the neighboring RBCs. I'm going to talk about this and much more in this topic for leukopenia and leukocytosis pathology. These presentations are actually ancillary material to this fundamental book on pathology, Medical School Pathology and Step 1 Review. Literally has everything in it that you need to know to advance, to do great, to succeed, to get the score that you need, to get the... Actually, you don't even need scores anymore. That's why people are failing, right? People are taking step 1 kind of lackadaisically. Don't let that be you. Get the most useful resources and utilize them, okay? I believe in you. You can scan this image with your phone and look up the book right now if you still need it, but you probably got it a long time ago because you're ahead of the game. Anyhow, let's talk about leukopenia and leukocytosis. Hematopoiesis is a stepwise maturation of CD34 positive hematopoietic stem cells in general. From the bone marrow, hematopoietic cells develop and are released into the blood. A white blood cell count of 5,000 to about 10,000 per microliter is considered normal. Leukopenia is a low white blood cell count, below 5,000. Leukocytosis is a high white blood cell count, greater than 10,000. Oh, you know this image. Can you describe it to me? Can you at least point out the two activated lymphocytes? All right. Good job. Leukopenia and leukocytosis. Okay, so a decrease in one particular cell lineage or an increase in another is typically the cause of a low or high white blood cell count. Leukopenia is a low white blood cell count, right? I'm hammering this home because you're going to have to know these values. Leukopenia below 5,000. Neutropenia is a reduction in the amount of circulating neutrophils. Causes of neutropenia include drug toxicity, such as stem cell damage from chemotherapy with alkylating agents, which reduces the generation of white blood cells, particularly neutrophils. Also, a severe infection, such as gram-negative sepsis, causes more neutrophils to enter the tissues, which lowers the amount of circulating neutrophils. Pharmacologically, GM-CSF or G-CSF can be administered to increase granulocyte production and lower infection risk. These are also known as, or there's something known as filgastrum or pegfilgrastim, which promotes granulocyte production as well. Lymphopenia is a decreased amount of lymphocytes. Causes of lymphopenia include immunodeficiency, high stress states, like having to study for step 1. Your cortisol is probably high. Make sure you're exercising, eating properly, getting sun, hanging out with your friends, calling your mom, your pops, petting dogs. Stay happy. Stay happy. That's very important, right? Smile. Remember, people love you and are rooting for you. I'm rooting for you. Let's lower your stress. Be stressed enough to do your work and do it great, but don't go down that dark road. Anyhow, that's enough of my 2 cents. Autoimmune destruction can cause leukopenia, and radiation therapy can as well. Wow, look at those activated T lymphocytes. This patient must have mono. Leukocytosis is a high white blood cell count, which is greater than 10,000. Hammer on home these values, they must be important. Increased levels of neutrophils in the blood are known as neutrophilic leukocytosis. Causes of neutrophilic leukocytosis include bacterial infection or tissue necrosis. Reduced Fc receptors characterize immature cells. Fc receptors, also in this case known as CD16. High levels of cortisol inhibit leukocyte adhesion, which causes a marginated pool of neutrophils to be released. Increased circulating monocytes are referred to as monocytosis. Causes of monocytosis include malignancy or chronic inflammatory conditions, such as autoimmune and infectious diseases. Increased circulating eosinophils are referred to as eosinophilia. Causes of eosinophilia include allergic reactions, specifically type 1 hypersensitivity reactions, parasitic infections, helminth infections, and Hodgkin lymphoma. Eosinophilia is usually associated with interleukin 5. Basophilia is the term for elevated basophil counts in the blood. Basophilia is a condition that is characterized by increased basophils. Basophilia is a common feature of chronic myeloid leukemia. Remember that. Basophilia is a common feature of chronic myeloid leukemia. What are other common features of chronic myeloid leukemia that you might see? Smudge cells. Don't worry, we'll get into that in detail when we hit the leukemias and lymphomas. But for now, remember that basophilia is a common feature of chronic myeloid leukemia. I'm going to ask you about it later. Increased circulating lymphocytes are referred to as lymphocytic leukocytosis. Causes of lymphocytic leukocytosis include viral infections and Bordetella pertussis via lymphocytosis promoting factor. Now let's talk about infectious mononucleosis. Infectious mononucleosis causes reactive CD8 positive T cells to increase and present as lymphocytic leukocytosis. Infectious mononucleosis is caused by viral infections, specifically Epstein-Barr virus, most commonly, but occasionally cytomegalovirus can do it as well. Here on the right, we have an image from a patient with infectious mononucleosis. Note the lymphadenopathy. Epstein-Barr virus is a saliva-borne infection that typically affects teenagers. That's why it's known as kissing illness. Epstein-Barr virus primarily causes pharyngitis by infecting the oral pharynx. Symptoms of infectious mononucleosis include lymphadenopathy, as we just saw, splenomegaly, as well as hepatomegaly. Due to T cell hyperplasia in the lymph node paracortex from the CD8 positive T cell response, the patient experiences widespread lymphadenopathy. T cell hyperplasia in the periarterial lymphatic sheath is the cause of splenomegaly. Hepatitis with hepatomegaly and increased liver enzyme levels is caused by the liver injury and infiltration. Laboratory findings of infectious mononucleosis include high white blood cell count, i.e. leukocytosis, atypical lymphocytes, as you saw now 3 times on the peripheral blood smear. Those are specifically reactive CD8 positive T cells. A positive monospot test. IgM antibodies that react with horse or sheep red blood cells are detected. Those are heterophile antibodies. And also note that the Epstein-Barr virus viral capsid antigen is detected using serology to provide a definitive diagnosis. Note that it may take about a week of infection for the antibodies to be detected in infectious mononucleosis. Also, as we said, infectious mononucleosis may have cytomegalovirus as a probable etiology if the monospot test results are negative. So keep that on your differential. Complications of infectious mononucleosis include higher risk for splenic rupture, recurrence of infectious mononucleosis, and B-cell lymphoma. The virus's dormancy in B cells increases the likelihood of recurrence, as well as B-cell lymphoma. Patients are advised to refrain from contact sports for a year. Yes, a year. Patients can literally rapidly die due to hemorrhage from a splenic rupture associated with trauma during an infectious mononucleosis infection. It cannot be overstressed to advise against contact sports and activities in this setting. You got it? I know you got it. I know you're going to remember all of this. You know it all. You're so smart. You got it. Wow, you're really making me proud. You're hammering through these lectures. You got your book. You're taking notes. You're remembering. You're so studious. Wow, that's great. That's fantastic. You're making me really proud. I'm going to see you on the next lecture. Till then, keep your head up.